Good afternoon, Madam Chair and members. Charles Bakke with the California Association of Health Plans, representing all of the Medi-Cal managed care plans that work in partnership with the department. Unfortunately, today we are here in opposition to the proposal that we've seen so far from the state for a Medi-Cal drug formulary. This is a classic case, in our view, of robbing Peter to pay Paul. You are going to maximize the drug rebate revenue to the pharmacy wing of DHCS, and you're going to actually increase costs to the managed care division of DHCS. And we just don't think that makes sense, considering that the alleged rebate revenue is such a small percentage of the state's overall drug spend. Other states have tried this approach, and their experience has proven that it hasn't worked. In fact, in Ohio, it reversed its statewide formulary in less than a year and returned drug management back to the health plans. Those plans discovered that when they received the benefits back, the generic use had dropped and brand name had increased. And that, of course, led to higher costs in that state. Health plans in Texas also report increased drug costs for the use of their statewide formulary. It's also important to note that some of our larger health plans have only one formulary for all of their lines of business, meaning that they negotiate for their commercial lives, their covered California lives, their CalPERS lives, and their Medi-Cal lives, one formulary. So to the point of this being a complex situation, if you take away one line of business from their formulary, what is the impact to commercial rates in other marketplaces? Are you actually increasing costs for individuals and employers, including those that covered California? The department in the materials appears to concede that it will increase costs. This proposal will increase costs for managed care, and we obviously agree. And we think that's kind of a counterproductive trade-off that we don't think merits that kind of major decision. We do, however, want to be constructive partners with the state and not just say no. And we do believe that there is a way to try and increase state rebates for brand name pharmaceuticals, and that is to go on a drug-by-drug basis for those drugs that are high cost with no generic equivalent that we believe we can come to agreement should be carved out of managed care and purchased by the state on a fee-for-service basis with rebates. However, asking us to bear the risk of that and to take hits to our capitation rates for not having pharmacy management controls would be the wrong approach. So we do think there's a place to go here. Obviously, we haven't had a stakeholder meeting yet with the department, so we haven't been able to really talk about this in detail, but right now we're opposed to the proposal as we've seen it. Thank you.
Okay, thank you very much.
Thank you, Madam Chair and members. Maureen O'Haron, representing Molina Healthcare of California. We serve nearly 400,000 Medi-Cal beneficiaries in 5 counties, and we're strongly opposed for the reasons mentioned by Jennifer Kent and Charles Bakke, as well as the points that were made by Legislative Analyst's Office. I won't repeat what's been said, but I'll try to put a little bit of individual detail from Molina's experience, because we do operate in 10 states. We use a pharmaceutical benefits manager, and we use the purchasing power that they have of hundreds and thousands of other lives that they negotiate for. And so we benefit from that in getting lower costs. That's the best way we feel to get value for the state's dollar. And our PBM tells us that for every 1% reduction in generic use, we see a 2.5% increase in costs. And in the other states where we've seen states try to do this, that is exactly what has happened. We were one of the states in Texas that saw this, and generic use dropped 10%, and we did see the healthcare costs rise. In Ohio, again, we were there. Generic use dropped 10 percentage points. Costs spiraled upward by as much as 16% for the state, and that's when they gave it back to us. And we had to then transition people back into generics. Our generic use for all of our Medi-Cal members is approximately 89%. And if we're forced to go to a more brand-heavy, state-dictated formulary, we expect to see another drop. In 2013, our pharmacy expenditure was about $78.5 million, and if we see a 10% percentage points drop in generic use, that will mean an increase of approximately or nearly $20 million, which is about a third of the savings that the state is expected to get, or of the supplemental rebates that the state is expected to get. And we're just a small plan. We're not one of the largest plans doing Medi-Cal in the state. So if you just multiply that, include LA Care and Inland Empire, you get way beyond $65 million. In addition, we oppose the elimination of the kinds of tools like treatment authorization requests for these drugs. It will only lead to more drug abuse and fraud and misuse of drugs, which is a serious problem, as you know, with our young people. Our pharmacy costs are only 14% of our total costs, and if they go up by 25%, as this would probably do, it also squeezes out our ability to invest in other services for our members. For example, Molina has invested in shuttle bus programs in some of our counties where we do business in order to provide our members with the ability to get to their appointments, to the pharmacy, to grocery stores to get healthy food. We've also opened new clinics in underserved areas where our physician partners were unable to go. I believe it was 2012 alone, we opened 4 clinics in the Inland Empire where there was an underserved population and an unmet need. We look forward to working with the department. As Mr. Bucky said, we think that there is a lot of opportunities to look at some of these high-cost drugs like Sovaldi, which is the new hepatitis C drug that has come on the market, and see if there is ways that the state can be helpful in getting the kind of reductions and helping us out in that way. So with that, we strongly oppose this proposal and urge you to reject it. Thank you.
Thank you very much. Vanessa Kahina with the Western Center on Law and Poverty. We think that there might be some merit to this proposal, but we go in with some leeriness and trepidation as to how the current trailer bill is written. We've talked about continuity of care in the course of going from generic to possibly more name brand. I think that a lot of folks who switched over in the SPD transition who are on name brand drugs, there have been some issues that our local advocates have brought up as to their continuity and their ability to get drugs from their plans that are off formulary. So to the extent that the trailer bill was maybe written a month and a half ago or so, and the conversations might have moved between plans and pharmacists and drug manufacturers, that might be something to consider. We do like a belt and suspenders approach when approaching Knox-Keene provisions in these kinds of bills. So we'll continue to want to work together on that and look forward to the stakeholder meeting involving consumers in the upcoming week, I hope. And when we also talk about the review process and ways to get drugs that are off formulary, I didn't necessarily hear that consumers would be included in that. We work with many consumer organizations who also believe that this proposal might have some merit, also like the concept of uniformity and maybe getting to a place where the rebates will be in place and the savings are actually realized. So we'll move forward, like I said, with a little bit of leeriness, but we'll be back. I hope to hear this soon. Thank you.
Thank you very much. This obviously is a very complex issue, and there's very significant ramifications on the decisions that will be made. That's pretty clear. Another easy issue for you to work on, Mr. Douglas. So I'm sure there's no objection to continue to keep this item open. We look forward to hearing from the stakeholder groups. And can you just sort of outline for me what the stakeholder groups are that you will be gathering together?
Sure. So the two that we still have remaining for the initial set of stakeholder meetings is one with our Medi-Cal managed care plans, and then the second with the consumer advocates. And then again, we continue to have meetings as are necessary to talk through what the concerns are.
Yes, and the first two you've already had are
the pharmacy providers
Yes.
and the pharmaceutical manufacturers.
Okay, very good. Thank you very much. All right, so that will remain open. The next item is the impact of the minimum wage increase on Medi-Cal.
So the wage adjustment pursuant to AB 10 does potentially affect the Medi-Cal program. The effect of such an increase wasn't included in the January budget because staff were still evaluating the effect of the legislation and just didn't have any data at the time to know what the potential impact might be. We do intend to include estimates that we are working on as part of the May revision as we continue to do this analysis. Where we're looking is we see a potential need for adjustments really as it relates to certain long-term care facilities, such as skilled nursing and intermediate care facilities for the developmentally disabled. What we're trying to do right now is ascertain those providers, are they already paying wages that exceed minimum wage or not? And if they aren't, we will have to make rate adjustments that therefore would, obviously increase costs in the Medi-Cal program. So that is the work that we're doing now. And with regard to our waiver programs, really that's linked to that same analysis, since the reimbursement rates in our waiver programs are really closely linked to Medi-Cal fee-for-service rates. To the degree, again, we're seeing a potential need for an increase in the Medi-Cal fee-for-service rates, that may also flow through into the waiver program. So we are working on that analysis, and we'll have that something along those lines for the May revision.
Okay, very good. Any comments from members? Legislative analyst, Department of Finance, comments? All right, this item will remain open without objection. Next item, fingerprinting and criminal background checks.
So the department is proposing trailer bill language to comply with the Affordable Care Act requirements related to fingerprinting and criminal background checks. And as context, the department is responsible for enrolling providers into our Medi-Cal program. We enroll over 150,000 different types of providers. And as part of that, we're balancing both the need to bring on providers to participate in the program, as well as program integrity and following all the rules. Well, now under the Affordable Care Act, there are additional requirements to ensure that we are looking at the risk for providers based on their potential risk for fraud, waste, or abuse, and it's done through different levels of risk, which are in the Affordable Care Act, and regulations from limited, moderate, to high risk for screening. We are waiting for final regulations from our federal partners, but part of the rules will be to comply with where Medicare identifies high risk, and the committee analysis goes into more detail about this, that there are currently 2 different providers that are identified for high risk. We do currently right now with the Department of Justice, they are able to do criminal background checks and fingerprinting, but they can't provide it to us. The Affordable Care Act requires that the department actually have access to it, and that's what we're changing in statute. There is a question that you're asking about the relationship to IHSS, which is a Medicaid program, and the committee analysis does a really good job of laying out what really are the implications. Currently, IHSS does do these background checks, but under state law, it is not necessarily the case that the IHSS provider would be high risk. We're waiting for final guidance from our federal partners and the regulations and how it will comply and figure out where it fits in. But it's not that they are characterized as an immediate high risk. We would have to go through the process based on the final regulations and then look how it complies with our state law. Any questions? But the final point is the reason we need it now is it will right away, once the final regs go into effect 60 days after, we have to implement. So we really need the statute now. Thank you.
This question might not be totally relative specifically to this issue, but who bears the cost of the background checks?
Under this regulation, the actual provider will bear the cost.
Okay. I'm just wondering how that might be impacted if there are decisions with regard to the overtime issue, where many more workers will be brought into the system.
Well, so again, for IHSS, our hope is that it isn't. There already are requirements for fingerprinting, background checks, and state law, and how that's funded. So I don't think, we can follow up on what the but that area, I don't think it will have an intersection, but we're waiting for final guidance.
Okay.
But we can get back and talk to committee staff about that implication.
That's just part of the math that should be considered if it is relevant. Okay. All right, thank you. Any comments, Senator Monning? All right, LAO, Department of Finance. Public comments on this item? All right. This is an item that will be held open. Thank you very much. Next item is the ground emergency medical transportation issue.
Sure. So first, just to give a general overview on this program, it was established under AB 678 from 2011, and it provides for the ability for public ground emergency transportation entities to certify their unreimbursed Medi-Cal costs and receive supplemental reimbursement of the federal share of those unreimbursed costs all the way back to fiscal year 9-10. The program is a first of its kind in the nation, and therefore it took several years to work with CMS to get state plan approval. But as part of that, it ended up meaning that we realized we could actually claim additional federal reimbursement through that process. So that was a good process, although it took a long time. We're currently estimating that this will potentially result in about $50 million in federal reimbursement for each fiscal year. So for the 4 retro fiscal years, we're talking about a total of about $350 million in reimbursement. The department is currently accepting the cost reports from providers for those 4 fiscal years. We have approximately 110 providers who have signed up, and we're still accepting applications from other providers who might want to participate. We do anticipate the initial payments starting to be received by the providers in April, so coming up really quickly. So in terms of the VCP itself, we are asking for 8.5 positions, 5.5 permanent full-time, and 3 3-year limited term positions. There is no general fund impact here. The funding, the non-federal funding would come from reimbursement from the providers. The purpose of the positions are really to both operate the program and to do the appropriate cost report reviewing to ensure appropriate federal claiming. And we need the 3 3-year limited term because of the backlog of the 4-year retroactive period.
And so this is federal funding that will flow through back directly to the fire departments that have already provided transport, and is a reimbursement?
That's correct.
Okay. All right, thank you. Any other questions, comments? All right, LAO, Department of Finance. Public comments on this item. All right, thank you very much. This item is open for approval. A motion is in order. Senator Monning?
So moved.
Moved by Senator Monning. That item is approved. 2 votes, 1 not present. All right. Next item is MEDS modernization.
This is what we commonly refer to as our med system. This is has been the backbone to Medi-Cal eligibility. It's in essence a client index for all those on Medi-Cal, and it's used by over 35,000 different users, both for Medi-Cal. It's also been the index, so will be for Covered California. It's used across health and social service programs, including those in child welfare and the mental health system. It's a very important system, but it's over 30 years old. And as we move to new IT systems and development, it's time to look and modernize the system. And so we're coming forward with a proposal to do the planning, to look at how we design that new system. We don't want to do this in one fell swoop, so we need to make sure we're doing it right with an important planning process, and that's what we're requesting for these positions to do.
Question, comments? We'll have some public comments after we ask if LAO or Department of Finance has any comments. Legislative Analyst?
Sean Martin with the Legislative Analyst Office. We're recommending approval of this proposal, and we know that they're taking a new approach to planning the implementation of this project. Accordingly, we think there's value in trying this new approach, and that they should come back in the next budget year and report on how the process works, so the legislature is in a better position to evaluate whether it'd like to use this approach in the future.
All right, thank you very much. Department of Finance? Public comments?
Vanessa Kahina with the Western Center on Law and Poverty. We support the additional support for meds, particularly with the enhanced federal participation on this, as it is such an important system of record for Medi-Cal, but also Covered California, CalWORKS, and our SNAP program. So thank you, and we hope that you'll approve it.
Thank you.
Jennifer Kent, Local Health Plans of California. I think that this proposal is probably 10 or 15 years late in coming, from the standpoint that to think that you run a program of almost 10 million individuals on a database that was built in 1983 is simply irresponsible from the standpoint of if there was a failure of the med system it would be absolutely catastrophic when you think of all the programs that rely on it. So with that, we give it strong support and wish that with all due pass. So thank you.
Thank you very much. What?
Make it retroactive.
Yeah. What is the name of the system that's being used? No, I mean, I'm just wondering what the system is called. How old-fashioned is it?
It's in Cobalt. It's
Oh,
really,
my God.
really, yeah. And so we also do have the issues of staff. I mean, the staff.
Yes, I was
certain
reading that.
Staff, everyone knows.
The declining workforce skilled in
Yeah.
these technologies.
Yeah, we don't let them retire. They have to
Okay,
stay
all right,
on.
so they'll finally get to retire. That's good, that's very nice. Okay, this item is available for approval. Are there any other comments, public comments? Okay, so moved by Senator Monning. That's approved on a vote of 2 aye and 1 not present. Thank you very much. All right, the next item, number 14, the Breast and Cervical Cancer Treatment Program.
Sure. So this proposal is to extend 6 limited-term positions for an additional year and a half. The work of these positions is to really do eligibility determinations and renewal verifications and process requests for retroactive coverage for this really important coverage program for women. There was a question in the agenda about why there is a backlog and how this request proposes to address that. You know, the backlog is really just a result of the volume of applications and renewals that the staff were having to process. We do anticipate a slowdown in the number of applications given the expansion in covered California, and so we believe if we have these positions extended, the backlog would be able to get reduced much more quickly.
All right, well, that's good news. Any other questions? LAO, Department of Finance, public comments. This item is available to be approved. Is there a motion?
So moved.
Moved by Senator Monning. That is approved on a vote of 2-0. Thank you. Next item, baseline HIPAA staffing.
13 and a half positions to continue our work on compliance with HIPAA. This relates to both privacy as well as all the IT codes and transaction requirements. And so this is needed. There continues to evolve, especially with the Affordable Care Act, and we need these positions to implement new rules. How do we standardize sharing of data? It complements the work we'll talk a little bit on related to electronic health records, but very important for our continued infrastructure, working with our health plans as well as eligibility systems.
Okay, thank you very much. Any comments, Senator Monning? All right, Department of Finance or legislative analyst?
Adam Dorsey, Finance, just noting that these are already existing positions, so we're not adding new positions here.
Okay, great. Thank you very much. Any public comment on this? This item is available for approval.
So moved.
Motion by Senator Monning. That's approved on a 2-0 vote. Thank you. Next item, oversight on nursing home referrals to community-based services.
As part of our work on both nursing facility payment, we have a longstanding payment methodology for our nursing facilities under AB 1629. A component was that to look at ways that we continue to transition individuals out of nursing facilities back into the community. We also do that through a program, a federal program called Money Follows the Person. There was new statute that the legislature enacted on analyzing data that comes through CMS under the minimum data set, MDS, that asks individuals in nursing facilities whether they would like to transition back into the community. We are in the final stages of finishing that report and moving it through and to the legislature. So I apologize for the delay. We will get it very soon, and we'll be able to provide that data and do a briefing as needed. There is a question in the meantime about what are we doing, other ways we're working to do transitions. And again, the money follows the person is a big focus of us, and we continue to look at new approaches. We are looking, for example, at we do the authorizations of nursing facility days and fee-for-service through my department, and providing that data on authorizations to our community partners for Money Follows the Persons so that they can follow up and see if there is interest in those beneficiaries and transitioning back to the community. So we'll continue to look at different efforts in the meantime. Important. It intersects again with our coordinated care initiative. I know it's not on the agenda, but about rebalancing and providing the right work for our health plans, for our community partners, intersection with home and community-based services, so individuals can remain in the community and can get the right care at the right time. So we will continue to do that, and most importantly, get you this report.
Okay, thank you very much. When do you think we'll have the report, since it'll be a year overdue next month? You knew I was going to ask that question.
Yeah, you know, when this is where I can't get, it needs to go through, it needs to be part of the administration, so I can't give you an answer as soon as possible. I will personally make sure it moves
So are you
quickly.
saying it's off your desk and off someone else's?
No, it needs to come to me, but it will come very soon, and then
Okay.
I will make sure it goes quickly through the rest.
All right, we'll keep. So we'll keep bugging you.
Yeah.
All right, thank you. Thank you very much.
People are running in the department as we speak.
Okay, thank you very much. Whoever out there working on it, please. Okay, thank you. So this item, any questions, comments? Legislative analyst?
None, Madam Chair, except that our office also looks forward to the Blue Civic report.
Thank you. Department of Finance? Okay. All right. Public comments? All right, this item will remain open. Okay, next item, Medi-Cal electronic health records, meaningful use of federal grant.
Okay, the committee announced, put forward some information about our ongoing efforts to expedite the adoption of electronic health records and information sharing. And really, you know, at the core is our focus on making sure that we're sharing clinical information to improve health outcomes, to better coordinate care, deliver care. It fits in all our work we're doing on payment and delivery reform, is making sure that we have strong information sharing at the provider level, at the delivery system level. So we have been implementing since 2009 the HITECH Act and electronic health records, where we provide incentive payments, fully federally funded, to providers for adoption of electronic health records and what's called meaningful use, where they actually do use their electronic health records to share data or coordinate care better. Another important piece of the HITECH Act was the work of what are called, by our providers, providing technical assistance through provider networks, where they would go out to providers and help them learn how to adopt electronic health records and implement electronic health records. That money has ended. Now, under our electronic health record program, we can receive 90/10 reimbursement, and we have the ability, we've received approval to do it, and we've been looking for foundation support to draw down to in essence, to pay the 10%. And if we were able to do that, we would be able to continue that technical assistance, linking, again, back to the providers so that they could not just adopt electronic health records, but use the systems appropriately to coordinate care, to provide the data back to the state so that we could use the data on making sure that we're linking up with our health plans and sharing data to provide the most appropriate and effective care across the delivery system. So it fits all back together. So we're looking for that 10% still, and working with foundations and others.
Okay. Thank you very much. Any comments, questions? Yes, Senator Money.
So the information indicates that there's been about $1 billion in these incentive payments to date. Any rough estimate of what remains in terms of the total amount that would then indicate roughly what our state's 10% match might be?
Well, there are two different things. So I will need to get back to you on how much, because as part of the the HITECH Act, there was the opportunity for the provider to receive payments for actually achieving meaningful use, and there's different stages of meaningful use, and they'll get that, and that's 100% federally funded. So we manage the program and get the federal funds and get it out. There's another piece, which is, okay, well, how do we help those providers actually achieve meaningful use? And that's through technical assistance. And that is through, what the organizations were doing before. It's roughly around $40 million, that would require a 10% match. So that we know what the amount is. The other, I can get you the projected outlays, but it wouldn't be any general fund associated with it.
Great, yeah, and again, just kind of a ballpark, but that's helpful, just your explanation there. So on that last comment, the 40 million would have represented the federal contribution to that, to the technical assistance?
The amount, thank you. 37.5 is the federal, and then we would need of the 10%, which is a little over 4 million.
Right, great, thank you.
Sure.
All right, thank you very much. Legislative analyst, Department of Finance, public comments. Thank you very much. This item will remain open. Thank you all very much. Thank you. This hearing is adjourned. Thank you.